Welcome to the second part of Section 9. In this video, I'll focus on examples associated with the neurovasculature, which should be helpful in applying and integrating the material. Let's get started. Okay, the first question. A 68-year-old right-handed woman presents with right-sided facial paralysis, sparing the forehead, and paralysis of the right upper limb. Rupture of an aneurysm likely occurred near what vessel? Okay, from the question we know that the patient has right-sided facial paralysis, sparing the forehead, and paralysis of the right upper limb. These symptoms should immediately make you think of the homunculus and its vascular supply. Let's pull up the homunculus so you can more clearly see what's happening. This is figure 8.6, which shows the homunculus. From this image, we can see that our patient has damaged this region of the homunculus because we know that the patient is experiencing paralysis of the upper extremity and the face. Recall that the lateral portion of the precentral gyrus is supplied by the middle cerebral artery, or MCA. The question asks about rupture of an aneurysm, so with this information we can deduce that an aneurysm originating from the MCA must have ruptured. Because this patient has right-sided paralysis, and we know that the corticospinal tract decussates, we can deduce that the left MCA must be affected. Also note from the question stem that the patient had facial paralysis, but that the forehead was spared. This is because a lesion to the cortex would cause paralysis of the inferior aspect of the face, whereas a lesion to the facial nucleus in the pons would cause complete paralysis of the face. We cover this in more detail in Section 3, so go review that if you're confused. This is Table 8.5, which provides a list of clinically relevant aneurysms and the associated lesioned area and symptoms. From this table, we can see that rupture of an aneurysm in the MCA results in a stroke of the MCA distribution, resulting in identical symptoms to that of an MCA stroke, which is contralateral paralysis and sensory deficits of the face and upper limb. Okay, let's do another question. A 65-year-old right-handed male with a history of diabetes and a previous myocardial infarction presents with sudden loss of vision. Fundoscopy shows a cholesterol embolus. From what major branch of the circle of Willis did the embolus most likely originate? Okay, from the question stem, we know that the patient has vision loss, and fundoscopy shows a cholesterol embolus. We also know that the embolus came from the circle of Willis. Recall that the ophthalmic artery is a branch of the internal carotid artery, so the embolus must have originated from the internal carotid artery. Let's pull up an image so you can see what's going on. This is figure 8.46, which provides a general overview of the neurovascular anatomy. From this image, we can see the ophthalmic artery right here. Notice how this artery is a direct branch of the internal carotid artery, this region right here. So again, the embolus most likely originated from the internal carotid artery. Okay, here's another question. An 80-year-old right-handed male presents with paralysis of the right lower extremity. What vessel shown below is most likely occluded? In order to get this question right, you need to be familiar with the circle of Willis and the vascular supply of the precentral gyrus. Recall that the anterior cerebral artery, or ACA, supplies blood to the lower extremities. Because our patient has paralysis of the right lower extremity, or right leg, we can deduce that the left ACA must be occluded. From this figure, the left ACA is right here. From figure 8.6 of the homunculus, we can clearly see that our patient has damaged this region. This is because we know that the patient is experiencing paralysis of the lower extremity. Again, the medial portion of the precentral gyrus is supplied by the anterior cerebral artery, or ACA. Because this patient has right-sided paralysis and we know that the corticospinal tract decussates, we can deduce that the left ACA must be affected. So again, the left ACA must be occluded, which is right here. From table 8.4, we can see that an occlusion of the anterior cerebral artery results in damage to the medial aspect of the primary sensory and motor cortices. This results in contralateral motor and sensory deficits of the leg. Okay, the next question. A 67-year-old right-handed male presents with a blood pressure of 210 over 170 and left-sided paralysis and sensory loss. Imaging shows hyperintensities near the striatum. What vessel is most likely damaged? Okay, so hypertension and damage to the striatum should immediately make you think of the lenticulostriate arteries. Recall that chronic hypertension is highly associated with Charcot-Bouchard microaneurysms of the lenticulostriate arteries. So again, because this patient has an extremely high blood pressure, and we know that there are hyperintensities near the striatum, we can deduce that this patient most likely has damaged the lenticulostriate arteries. From figure 8.49, we can see that damage to the lenticulostriate arteries would result in ischemia to the internal capsule and basal ganglia. If the internal capsule becomes damaged, we'd expect the patient to develop contralateral paralysis and sensory deficits. This is because the corticospinal, corticobulbar, and corticothalamic tracts pass through the internal capsule and then decussate. From the question stem, we know that the patient presented with left-sided paralysis and sensory loss. Again, because the tracts decussate, we'd expect the right internal capsule to be damaged. So in this case, we can deduce that the right lenticulostriate arteries must be damaged. If the basal ganglia becomes damaged, we'd expect the patient to develop movement abnormalities, but this would be hard to predict unless more information was given about what part of the basal ganglia was damaged. From table 8.4, we can see that damage to the lenticulostriate arteries would result in contralateral paralysis and sensory deficits of the entire body. And again, the basal ganglia would also likely be damaged, which would result in movement abnormalities, but those would be hard to predict. Okay, let's do another question. A 77-year-old right-handed male presents with left-sided hemiparesis, loss of vibration and proprioception on the left side, and right-sided tongue deviation. What vessel is likely occluded? One of the most prominent clues of this question is right-sided tongue deviation. We've only learned about one vessel that, when occluded, can result in damage to the hypoglossal nucleus, which can cause tongue deviation. Recall that the anterior spinal artery, or ASA, supplies blood to this region, which explains the patient's deviated tongue. Remember from section 3 on cranial nerves that damage to the hypoglossal nucleus results in tongue deviation to the ipsilateral side, so we can deduce that the right ASA must be occluded. Let's pull up some images to review the patient's symptoms. On this slide we have figure 8.20 showing a transverse section of the medulla. Recall from part 1 of this section that the paramedian branches of the ASA supply blood to approximately this region right here. As we can see, the hypoglossal nucleus is right here, and because this nucleus is so medial and deep, it can become ischemic during an occlusion of the ASA or the paramedian branches of the ASA. Also notice how the medial lemniscus and the corticospinal tracts are both medial and receive blood directly from the paramedian branches of the ASA, so these are also affected. From figure 8.13 we can see that the dorsal columns ascend through the medial lemniscus and are responsible for vibration and proprioception. So damage to the medial lemniscus right here in an ASA stroke would result in contralateral loss of vibration and proprioception. In this case, we know that the right medial lemniscus was damaged, which explains the patient's loss of vibration and proprioception on the left side of the body. From figure 8.15, we can see that the corticospinal tract descends through the anterior pyramids, so damage to the anterior medulla in an ASA stroke would result in contralateral paralysis. In this case, we know that the right pyramid became ischemic, which explains why the patient has left-sided paralysis. Okay, let's do another question. A 67-year-old right-handed male with a history of diabetes mellitus and multiple myocardial infarctions presents with a 2-week history of progressive bilateral upper and lower limb paralysis and bilateral loss of pain and temperature. Proprioception and vibration are intact bilaterally. What vascular territory is likely ischemic? Okay, hopefully from the question stem you gathered that this patient has a history of atherosclerosis. We also know some part of the corticospinal tract is disrupted because this patient has bilateral paralysis. Likewise, we know that some part of the spinothalamic tract is disrupted because the patient has bilateral loss of pain and temperature. Perhaps most importantly, we know that the dorsal columns are unaffected because the question stem states that proprioception and vibration are intact bilaterally. Hopefully all of this information has made you think of ischemia to the vascular territory supplied by the anterior spinal artery, or ASA ischemia. Let's pull up an image so you can more clearly see what's going on here. This is figure 8.9, which shows a cross-section of the spinal cord. Again, this is anterior and this is posterior. And recall that after the ASA descends past the medulla, it supplies blood to approximately this region here. Notice how this vascular territory supplies the anterior and lateral aspects of the spinal cord, but spares the dorsal columns. Widespread atherosclerosis can result in ischemia to the ASA and the anastomosing branches that feed the ASA, resulting in ischemia to the area I've outlined here. In this case, the blood supply is compromised, resulting in damage to the corticospinal tracts, which explains the bilateral paralysis, the spinothalamic tracts, which explains the bilateral loss of pain and temperature, and as we can see, the dorsal columns are spared, which explains why proprioception and vibration are intact bilaterally. So again, the vascular territory supplied by the ASA is ischemic due to widespread atherosclerosis. Okay, let's do another question. A 52-year-old right-handed male with a history of coronary artery disease presents with vertigo, ataxia, dysphagia, and difficulty speaking. What vessel is most likely occluded? Recall from part 1 of this section that dysphagia and dysphonia, or difficulty speaking, are unique to lateral medullary syndrome. Lateral medullary syndrome is caused by damage to the posterior inferior cerebellar artery, or pica. Let's pull up some figures to make this clear. From figure 8.46, we can see that the pica is right here. Again, notice how the pica wraps around the lateral aspect of the medulla, hence the name lateral medullary syndrome. It's important to know that lateral medullary syndrome can also be caused by damage to the vertebral artery. This is because the pica is a direct branch of the vertebral artery, which we can clearly see from this image. So on the last slide, I said the answer was damage to the pica, but if you thought of the vertebral artery, you'd also be correct. From figure 8.20, which shows a transverse section of the medulla, we can more clearly identify the structures that would be damaged in lateral medullary syndrome. Again, this is anterior and this is posterior. And the pica supplies blood to the lateral medulla, or approximately this region here. Recall from part 1 of this section that it's most important to remember that the nucleus ambiguus is damaged in this syndrome. Recall that the nucleus ambiguus contains motor information from cranial nerves 9 and 10. From section 3, recall that cranial nerves 9 and 10 provide motor output to the pharynx and larynx, so damage to these structures would result in dysphagia and dysphonia. Also notice that the vestibular nuclei are right here, so damage to these nuclei explains the patient's vertigo. The patient also has ataxia, which can be explained by damage to the inferior cerebellar peduncle right here. From table 8.4 and this image, the patient also could have presented with a number of other symptoms. However, in order to have gotten this question correct, you needed to recall that dysphagia and dysphonia are unique to lateral medullary syndrome. Again, this is due to damage to the nucleus ambiguus. From table 8.4, we can see that damage to the posterior inferior cerebellar artery or the vertebral artery can both result in lateral medullary syndrome. On the right, we have a list of structures that are compromised and the corresponding symptoms. Okay, let's do another question. A patient presents with Horner syndrome, nystagmus, right-sided facial paralysis, and taste deficits. What vessel is most likely occluded? Recall from part 1 of this section that facial paralysis and taste deficits are unique to lateral pontine syndrome. Lateral pontine syndrome is caused by damage to the anterior inferior cerebellar artery, or AICA. Let's pull up some figures to make this clear. From figure 8.46, we can see that the AICA is right here. Again, notice how the AICA wraps around the lateral aspect of the pons, hence the name lateral pontine syndrome. From figure 8.18, which shows a transverse section of the pons, we can more clearly identify the structures that would be damaged in lateral pontine syndrome. Again, this is anterior and this is posterior. The AICA supplies blood to the lateral pons, or approximately this region here. For this syndrome, it's most important to remember that the facial nucleus and the solitary nucleus are damaged. Damage to the motor aspect of the facial nucleus will result in total ipsilateral facial paralysis. Recall that the solitary nucleus contains sensory information from cranial nerves 7, 9, and 10. So knocking out the sensory aspect of the facial nerve would result in taste deficits from the ipsilateral anterior two-thirds of the tongue. On the other hand, knocking out sensory aspects of cranial nerves 9 and 10 would result in more vague symptoms, which we explained in part 1 of this section. So again, facial paralysis and taste deficits from the anterior two-thirds of the tongue are symptoms unique to lateral pontine syndrome. Also notice that the vestibular nuclei are right here. So damage to these nuclei explains the patient's nystagmus. The patient also has Horner syndrome, which can be explained by damage to the descending sympathetic fibers from the hypothalamo-spinal tract in the lateral tegmentum, which is about right here. From table 8.4 and this image, the patient also could have presented with a number of other symptoms. However, in order to have gotten this question correct, you needed to recall that facial paralysis and taste deficits are unique to lateral pontine syndrome. Again, this is due to damage to the facial nucleus and the solitary nucleus. From table 8.4, we can see that damage to the anterior inferior cerebellar artery results in lateral pontine syndrome. And on the right, we have a list of structures that are compromised and the corresponding symptoms. Okay, let's do another question. An 88-year-old right-handed female presents with quadriplegia and bilateral facial paralysis. An astute medical student notices that the patient has the ability to respond by blinking. What vessel is most likely occluded? Recall from part 1 of this section that complete paralysis and facial paralysis with the ability to blink is unique to locked-in syndrome. Also recall that locked-in syndrome is caused by damage to the basilar artery. Let's pull up some figures to make this clear. From figure 8.46, we can see that the basilar artery is right here. Again, notice how the basilar artery is a midline vessel that supplies blood to the medulla, pons, and the midbrain. Because so much of the anatomy is affected in this type of lesion, I find it most helpful to focus on the structures that are spared. In order to see this, let's focus on the midbrain. This is figure 8.16, which is a cross-section of the midbrain. This is anterior, and this is posterior. From the last image, we know that the basilar artery is about right here. The branches of the basilar artery dive deep into the brainstem, so much of the anatomy in the midbrain is damaged. However, the oculomotor nerve right here is one of the deeper structures of the midbrain and is typically not damaged during occlusion of the basilar artery. This is why patients can blink and move their eyes vertically. The reticular formation and the tegmentum are also spared, which explains why the patient has preserved consciousness. Recall from part 1 of this section that the reticular formation is a group of many nuclei throughout the brainstem, so it can't be easily identified on one image like this. The tegmentum is also a general area within the brainstem, but on this section of the midbrain, it's located throughout this region about right here. Again, preservation of the reticular formation and the tegmentum explains why the patient has preserved consciousness. From table 8.4, we can see that damage to the basilar artery results in locked-in syndrome. On the right, we have a list of structures that are compromised and the corresponding symptoms. But again, I find it most helpful to recall those structures that are not damaged, which is shown right here. Okay, let's do another question. A 26-year-old right-handed male presents with abnormalities of the right eye, including mydriasis, ptosis, and difficulty adducting the eye. An aneurysm from what vessel is most likely responsible for the patient's symptoms? Recall from part 1 of this section that mydriasis, ptosis, and difficulty adducting the eye are unique symptoms associated with damage to the oculomotor nerve, or cranial nerve 3. Remember, an aneurysm originating from the posterior communicating artery, or PCOM, can compress the oculomotor nerve, resulting in the symptoms described in this vignette. Let's pull up some figures to make this clear. From figure 8.47, we can see the posterior communicating artery right here. Recall that the oculomotor nerve passes between the superior cerebellar artery and the posterior cerebral artery as it projects anteriorly like this. This means that an aneurysm originating from the PCOM right here could compress the oculomotor nerve, resulting in the symptoms described in this vignette. From table 8.5, notice that an aneurysm originating from the PCOM can compress the superficial parasympathetic fibers of cranial nerve 3, resulting in mydriasis and ptosis, and compression of the deep somatic fibers of cranial nerve 3 can result in paralysis of the corresponding ocular muscles.